Before embarking on a regional technique, venous access must be secured along with basic monitoring of vital signs. For the midhumeral block, the puncture point is the junction of the mid and upper third of the humerus, which will correspond to the deltoid insertion. At this point, it should be easy to palpate the brachial artery.
Now what I want to do is a transverse subcutaneous injection so that the initial injection through the skin is relatively pain-free, but also this will get intercostal brachial nerve as well. So you're going to feel the artery. You've got such big biceps, I can't feel the artery easily. I've identified the artery there. So I'm going into the skin and subcutaneous tissue. It goes up to 2 milliamps. And now I'm imagining that I'm passing the needle along the superior surface, the anterior surface of the artery. And you can see some pronation there. Now I want to just firm that up. Right, there we are. So we can turn the current down a bit, please, Jim. So that's pronation, not much finger flexion, but I don't think he's got much finger flexion anyway. And Jim's turning that down, that's 1.8. Keep it on for bursts of 2 seconds. That's it. Well then, hold it there, Jim, that's perfect. That's 1 milliamp now. Just see if I can identify that a bit more, a bit better. And we can turn the current down, that's 1 milliamp. So we aspirate now, no blood, no thunder, and inject. And this is just 0.25%. Jim, have you got some 0.5% there, please? Yeah, you change it. Inject some 0.5% there, remember that. Lovely, aspirate and inject too. And inject 5 mils. Lovely. And turn the current back up to 2 milliamps, please. So that was median. We'll now go for ulnar. We could use 0.25% for ulnar. We'll go back up to 2. So back out to the skin and subcutaneous tissue. Raise the hub of the needle and look along the medial surface of the artery, aiming slightly posterior to see whether we can pick up some ulnar stimulation. That's got adduction of the thumb. That's probably as close as we're going to get it. So if you could aspirate and inject, please, Jim.
0.5%?
Yeah. That's as close as we're going to get for ulnar. 5 mils, yeah. And then change syringes.
0.5%?
0.5% again. Now we're going to operate on the thumb, so we definitely want musculocutaneous. We're on 2 milliamps, so we slowly withdraw the needle, just in case I get better stimulation of ulnar, but I'm not. My fingers of the left hand are still on the artery, and I'm going to aim towards the upper surface of the humerus to stimulate musculocutaneous and get biceps contraction. Good. Aspirate and inject, please. Sorry about that. And inject for 5 mils. Aspirate again. Inject 10 mils. That's 0.5%. Lovely. Change syringes to 0.5% again. We're going to come out of the subcutaneous tissues again. We're still stimulating on 2 milliamps. I want the needle now to pass beneath the artery towards the posterior surface of the humerus, aiming towards my thumb of the left hand, which is on the deltoid insertion. So I want to pick up the radial nerve and get extension of the wrist and extension of the fingers. And there we are there. Aspirate and inject for me, please, Jim. Goes immediately. 10 mils there. So we've got musculocutaneous with 10 mils of 0.5% marking. We've got radial with 10 mils of 0.5% marking. We're still stimulating on 2 milliamps. You've got some 0.25%. And the only other thing that we might do is just make sure that we get intercostal brachial and medium cutaneous nerve of arm. So starting from, we don't need to stimulate for this, so starting above the artery, keeping the needle subcutaneous, going right into the posterior fold of the axilla. Aspirate and inject from the please. Lovely, and inject and as you inject, I'll withdraw the needle, leaving a subcutaneous line, local anesthetic. Carry on injecting again. That's it, that's good. Lovely. Now, if we were unsure of whether we'd got radial, we can pick up the radial at the cubital fossa. So at the level, very gently with your hand, sorry about that. So at the level of the epicondyle, so at the crease of his elbow, we palpate the brachial, the biceps tendon, and the mass of the body of brachia radialis at the apex of the lateral border of biceps and the medial border of brachia radialis. We place the needle into the skin, come up to 2 milliamps again, and pass the needle just past the lateral border of the humerus, over the lateral epicondyle. We should pick up the radial nerve. So we can aspirate and inject, please, Jim. It's 5 mils of 40% marking. If we hadn't picked up musculocutaneous at the midhumeral point, the musculocutaneous becomes cutaneous at this puncture point. And so we can just infiltrate a little bit of local anaesthetic at that point there, just 2 mils there, Jim, please. And that should get the cutaneous branch. And then if we wanted to get median nerve, we palpate the brachial artery and go immediately medial to the brachial artery. So at the level of the crease of his elbow, palpate the brachial artery. Can you turn the current down a bit here, Jim, just to see how accurately we've got it? Lovely, and that's at 0.7 milliamps. 0.5 milliamps, that's fine, Jim. Aspirate and inject. And that looks nicely medium. Easy to inject and not painful. Lovely, thank you very much. So we've finished there. Well done. How does that arm feel? Does it? No, do you notice any difference?
It's like a dull head, but that's about it.
Right, okay. Well, we'll leave that, got a bit of a squodge of local anaesthetic there. Good, excellent.
Payunk Medical Technology produce a range of equipment suitable for regional anaesthetic techniques using nerve stimulation to aid accurate localization. A range of needle tips and lengths are manufactured, through which catheters may be passed for prolonged analgesia. A choice of stimulating or non-stimulating catheters are available. The facet-tipped needle with a 20-degree bevel allows easy passage of a catheter when the needle is in the same axis as the nerve or plexus. This would include an axillary approach to the brachial plexus or a block of the femoral nerve. The TUI tip or sprot tip allow the catheter to exit at an angle which may be useful for interscalene and vertical infraclavicular approaches to the brachial plexus, or with a catheter technique for the lumbar plexus.